And Dr. Nunn, I'm going to turn it over to you. Thank you so much.
Thanks, everybody. I want to just open by thanking LaShannon and Sarah for having me here today, and also acknowledge that Latunja Sockwell is one of our team members, and she's a native Arkansan and is helping us do some HIV prevention projects in Arkansas. So thank you so much for having me. I also want to acknowledge that my colleague Yelena is on the call listening. I'd love to just know a little bit about the audience and who I'm talking to so I can tailor this webinar. So if people are tuned in and want to just say their names and who they are and what they do, that would be great for me. So, and if not, I'll just go ahead and get started.
Hey, Amy, I'll start. This is Eddie Ochoa. I met you back when you used to work for Senator Lincoln.
Hey there. It's been a while.
Yeah. And I'm the section chief for community peds now at UAMS and ACH. I'm also a board member at Jefferson Comprehensive Care, which is a FQHC in Pine Bluff, as you probably remember.
Yeah.
And our division runs the Head Start and Early Head Start program in Pulaski County as well.
Terrific. Great to hear from you.
Yeah, likewise.
Dr. Ochoa, actually, when Dr. Nunn was here in town, her last visit to Little Rock, we actually took her by Jefferson Comp. She actually visited the Open Hands shelter, and she actually went to the College Station shelter as well. So I gave her a quick tour of Jefferson Comp, and I shared with her the work that Jefferson Comp was doing for the identified patient population.
Great.
All right. Are most of the people on the call, do you have a clinical background? Okay, well, if nobody tells me, I get to talk about whatever I want.
Dr. Nunn, just looking at the participants, it's a diverse group. So you have from clinicians to community outreach individuals to just subject matter experts that are participating on the call.
All right, sounds good. Well, I'll go ahead and get started. And it's a small group, so y'all feel free to interrupt me. And if you have questions as I go. And we're going to do, I think, a screen share. Nobody judge me for my messy desktop and all the clutter on my computer. All right, Sarah, you want to share the screen? Do I need to go on and do mine?
Yes, share your screen.
Okay, here we go. So what I'm going to talk today about, I do HIV research, but I also have a diverse portfolio of service projects related to HIV, but also a bunch of other things. I run Open Door Health, which is a clinic in the background here. It is the first LGBTQ clinic in Rhode Island. It opened just in March before our COVID pandemic mushroomed, and mostly doing telemedicine now. I am a native Arkansan, and today I'm going to talk about some of the work that I have done in the Deep South with faith leaders and engaging the African American faith community in the fight against HIV. I'm going to talk about the state of the science, what we know and don't know about what works with working with Black clergy. And really hope to take you to the frontier where the science is, but also provide a brief roadmap of what we have done that has really been effective in working with African American clergy. Because I am running through the slides, I think I can't see the chat feature. So feel free to put a message in the chat. I'm going to ask Sarah to facilitate, but also just feel free to interrupt me. So LaShannon and I worked together for Senator Blanche Lincoln, gosh, almost 20 years ago now. And once you do outreach like that, you develop a deep bond with pretty much everyone. And we ran into each other at an Ending the HIV Epidemic conference at the end of last year, and we're reunited. And just so excited to be developing some collaborations in Arkansas. So I've been working in Mississippi for some time now, and excited to be working with LaShannon and Latunja and others and the health department as we begin to develop some collaborations with clergy in the state of Arkansas. So that's what I'm going to talk about. I'm going to talk about race, place, and faith, which are three of the things that I've been spending a lot of time on in recent years. So I think I'm going to open by just acknowledging where we are in 2020. And, you know, we've come so far. I'm an alumna of Little Rock Central. Go Tigers. But here we are in 2020, grappling with many of the same issues that we were in 1957 when Central was forcibly integrated by the National Guard. This is a picture of some of my girlfriends from my 20th high school reunion about 4 or 5 years ago. I did my training in New England, but I think I did my real training at Little Rock Central, which was where I learned about the role of race in the fabric of contemporary American life. And the lessons that I learned there I've carried with me throughout my career. And I'm going to talk a little bit about race. Sometimes it's difficult to talk about race, but I can't think about a better time to talk about it than now, given where we are. So just getting back to HIV, as most of you are on the call probably know, the federal government for the first time, we're 30 plus years into the HIV epidemic. We've never really made a big commitment to eradicating HIV in this country. It's actually possible now with so many different technological advances in the last few years. We now have one pill once a day for both treatment and prevention for most people. And we have a network of community health centers, thousands of them across the country, that have infrastructure to help deliver the interventions. But we've never had a coordinated effort to do that. Last year in Trump's State of the Union address, he committed to ending the HIV epidemic across the country. And I remember I was laying in bed late at night. Sometimes I'm, halfway paying attention to the State of the Union address. And he said, and we're going to end the AIDS epidemic. And I just almost rolled out of bed. I couldn't believe that I'd heard that come out of his mouth. And then in the next couple of days, CMS, Medicare and Medicaid, announced with great fanfare an execution plan. It includes making major efforts to scale up HIV screening, treatment, care, and PrEP, pre-exposure prophylaxis, in 48 counties and 7 states with a rural disease burden. This is a snapshot of where those places are, what we now call, and what's now more familiar, the word hotspot, where HIV infection rates are quite high. You'll note that there are several places in the Deep South where a lot of HIV infections are concentrated, including in Arkansas. I have, what I'm going to talk about today is what I'll propose is a roadmap for how we do it. So the first thing is we've got to talk about place. Where you live matters. Your social networks matter. And as evidenced by the maps tell us exactly where we need to go. For many years, we have not targeted our strategies geographically. Now the federal government has made a commitment to geographically focus interventions. I really think we also have to talk a whole lot more about race. Most of new infections are concentrated among Hispanic Latino populations and also among African Americans. We have to intentionally and deliberately engage those communities in a much more thoughtful way. The disease burden in the Latinx community really gets very little attention, resources, and coverage, but you know, buried in the bowels of some of the CDC reports, you can read that infection rates among Hispanic MSM are higher than among African American MSM, and they surpassed African American infection rates about 2 years ago. That's something else that warrants culturally tailored interventions. If we want to eradicate HIV, we also need to be very deliberate and thoughtful about how we can more effectively work with faith communities. If you're from Arkansas, I probably don't have to convince you of this. Sometimes it's an uphill battle for me to convince my scientific colleagues it's important to work with Black pastors. That's something that I actually learned how to do when I was working with LaShannon about 20 years ago, and how I met Eddie was actually working with Hispanic leaders and faith leaders in Arkansas. When you work for a politician in the South, you learn how to do this, and it's not difficult. You really just have to show up and visit with people. And the last thing that I think is important for this roadmap is really figuring out how to bring all these things together with clinical interventions. You know, how do we get HIV screening, treatment, and PrEP to these heavily impacted communities and do it in a way that's culturally congruent and resonates culturally? So these are the things I'm going to talk about today. So for the last decade or so, I've been working a lot on geography. It seems like a no-brainer that if you know exactly where HIV infections are concentrated, that resources would be targeted to those communities. Well, it hasn't been that way historically. Our public policies have only recently begun to reflect those priorities. These are some articles this is an article we published in the American Journal of Public Health about 6 years ago, highlighting that where you live and the color of your skin affects whether or not you survive if you're infected with HIV. And we did this with geographic data from both New York City as well as Philadelphia, Pennsylvania. These trends are echoed in all of those hotspots across the country. These micro epidemics are akin to many of the ones that we're seeing now with the COVID crisis, but only recently has our federal government begun to focus on micro epidemics. So in my mind, I think that's exciting that the federal government is finally paying attention to HIV clusters. Not surprisingly, Arkansas also has hotspot clusters. One of the projects that Latunja and I are working on now is to engage African-American clergy in partnership with the health department and also some colleagues at UAMS in the hotspots that you see here, adjacent to West Memphis, Pulaski County, and the Mississippi Delta region. I flashed the Mississippi slide because we've done a lot of work on hotspots there. You can see that in Arkansas and Mississippi, and even in Tennessee, which is not on the map here, it's one singular epidemic right outside of Memphis there, and then others in the capital cities of Jackson and Little Rock. I think that these hotspots really make this a much more manageable undertaking. If we know exactly where infections are concentrated, we can and should, in partnership with community health services centers, bring and churches and all of the bring all of our resources to bear in these somewhat narrowly defined geographic catchment areas that have really high rates of infection. So why are we working with churches? Well, you all probably know that the African American churches play extremely important roles in the social fabric of the African American community. African Americans are much more likely to attend church and to participate in some organized spiritual activity, and also more likely to have more likely to they're more likely to have spirituality outside of organized religion play an important role in their lives. In addition, churches can do a lot of things that we cannot do well, that we don't do well in public health, like provide spiritual and social supports. They often have a geographic reach where we do not. And most importantly, churches can help shape social norms around health and well-being. This is a picture from one of the projects that I run called Faith in Action. This is a choir on World AIDS Day, and when one of the pastors was preaching about HIV. So when I started this work about a decade ago, I was actually living in Philadelphia, Pennsylvania, where my husband was training, and Philadelphia is home to the nation's first African-American churches. It's also home to Mother Bethel, the flagship institution for the AME diocese across the world, and some of the first Baptist churches. And I thought, Philadelphia has such high infection rates. Why aren't we engaging church leaders? There's a church on every corner in Philadelphia. You can't throw a rock without hitting a church in downtown Philadelphia and throughout Philadelphia in general. So I began working with the mayor's office of faith-based initiatives, an extraordinary woman named Marguerite Handy. And she helped us do outreach to the city's most influential faith leaders. And we wanted to ask them, what do you know about HIV? What are we doing well? What are we doing wrong? What do you understand about hotspots? How can we work with churches in a way that advances the movement, but that's also culturally congruent? And here's what we've learned. Oftentimes, the overwhelming, I will say, I've worked with 200 to 300 pastors during the last decade. I've never had a pastor tell me that they were unwilling to get involved. Most of them are overwhelmingly willing to do this work. So, a lot of people feel comfortable talking about church, sex and human sexuality at church. A lot of people don't. Messages that tend to resonate most are ones framed around these themes. Normalizing HIV screening and treatment, social justice, and human rights. A lot of behavioral frames, which is how HIV prevention was framed until about a decade ago. Behavior change, condoms, reducing concurrent partnerships. Oftentimes, those are messages that pastors feel may be incongruent with their Sunday morning services. So not focusing on behavior change, but focusing on HIV testing and treatment. We published this in a couple of different journals that I flagged here, but I think this was important because it really gave us a roadmap for how we could effectively engage clergy. We've used these themes and infused them into all of our public health service programs that we've done through our Faith in Action program. And it's funny because when I started this work, we engaged the pastors in Philadelphia, Pennsylvania's most influential African-American pastors. And I was just a junior scientist trying to get a toehold and do community work that I knew how to do. And at the end, Pastor Waller, who runs a church with about 15,000 people, said, how sad is it that it took a white lady from out of town to come and bring us together? I wouldn't have come out for you on a Thursday morning. I know y'all wouldn't have come out for me, but it's sad it took a white lady from out of town to bring us together. So we're all going to work together from here moving forward, and Dr. Nunn's going to organize it. And I had made no such commitment. So I was shocked. But then I completely agree with Pastor Waller that was incumbent upon me, and I was glad to do the work. And we, with the MAC AIDS Fund, developed a citywide HIV screening campaign, which I'll show you in just a moment. But that was the genesis of a lot of the work that we have done with Black clergy, and we have managed to sustain those programs over time. I have a lot of photos in my presentation because when I started doing this work, a lot of people said, you'll never be able to do this. The pastors are not going to get involved, and they're certainly not going to do it with a white lady. So I put pictures throughout the entire thing to show you what it looks like and to show that pastors are doing it. They are willing. This is a picture from a sermon with Pastor Joe May on World AIDS Day a few years ago in Jackson, Mississippi, where he gave among the most poignant sermons I've ever seen. And he said, please, Lord, forgive us. Forgive me for my silence on this issue, and forgive us for our collective silence as a church on this issue. And today we are starting a community dialogue about this, and he has sustained that effort for the last several years. As I mentioned, we worked with the MAC AIDS Fund. That's never happened in my life. I don't know if it'll ever happen again. They called me and said, are you the lady that's working with pastors? And I said, yes. And they said, we want to fund your work. And I said, are you kidding me? That's wonderful. I said, what do y'all want to do? And they said, well, you tell us. We don't know how to do this. And I said, well, I want to do a social marketing campaign. So they put us together with the Kaiser Family Foundation, and we developed a citywide social marketing campaign that subsequently ran on the buses and the subways in the city of Philadelphia. And we also had billboards placed across the city. We have some videos from that campaign that I also want to share with you guys. I'm just going to show one because our idea, our goal was to elevate the work and the voices of community leaders, not have them focus on us, but instead to elevate the work and the voices of Philadelphia's most prominent African-American clergy. So I just want to show you a couple of those videos so you guys can get a feel for what this looks like in practice.
My name is Alan.
Can y'all see the video?
Waller.
Can y'all see the video? I don't know if it's still my slides.
No, Dr. Nunn, we are not able to view the video.
Right, just a second. Let me pull it in. How about now?
Pastor here.
No, still the slides.
The video's not showing, Dr. Nunn.
Okay, let me see. Oh, hang on. I'm gonna get this. Sorry guys, bear with me. This is really worth y'all seeing. Let's try now.
My name is Alan.
Does that work?
Eric Waller. I'm
Yes.
the pastor
Yes.
here at Nunn Tabernacle Baptist Church. Nunn Tabernacle Baptist Church is the largest African American congregation here in the city of Philadelphia. We have about 15,000 members. Philadelphia, like any other city, is plagued with the challenges of urban living. HIV and AIDS is a real issue in our community. The church historically has had trouble talking about HIV and AIDS because we have so many varied opinions on the theology of sex. There was a starvation for real conversation. And so I made a commitment that I'm going to talk about sex. We've just normalized the conversation. This is a human issue about a disease. And so when we begin to look at the disease and we begin to address the disease, it is absolutely possible for persons with very divergent theological, political, sociological views to agree that we must fight the disease together. We truly are people who just care for and love humanity and accept people as they come because that's how Christ accepts us. I'm Pastor Alan Waller, and I am greater than AIDS.
All right, so I give that as an example because I think pastors can really help set the tone, and Pastor Waller is particularly remarkable. He's also led a big screening effort in Philadelphia, and he himself was diagnosed with COVID, and he has recovered. but he has an annual screening event every year, and has really made a huge impact on the Philadelphia community. The other thing that was so important was that his voice helped us set the tone, and that enabled us to recruit a lot of other influential pastors and enlist them in a citywide movement. So here's a research to practice. I want to show you guys what this, y'all saw the buses, the billboards, the subway wraps. This is what it looks like at church. So we have church bulletins that we can provide and customize to local congregations. This is one for a two-sided church bulletin that we've disseminated in churches in Mississippi. As I said, most pastors are willing to talk about HIV. For those that are less comfortable, this is a subtle way to introduce a conversation. Also, we have, this took me out of my comfort zone, being academic and somebody who runs a nonprofit organization, was pastor said, I need you to give me language that works for me. Give me something I can use at Bible study. So we took the themes that they told us that worked for them and combined them with scripture and gave them scripture that they could use to talk about HIV. The faith in action quote is one of those. This was something that one of my students did, whose parents happened to both be pastors, and she helped pull this together for me along with the to accompany the scientific work that we did. We also have done citywide screening and PR pushes. A few years ago in Mississippi, we were able to get 20 pastors to declare a state of emergency on the Capitol steps and call for a citywide screening, and they all preached about HIV on that day. And a lot of them did, they did stuff that they felt would be meaningful for their congregation. So some of them got screened in the pulpit, some of them got on the radio, some of them got on TV, some of them introduced the church bulletins, and all of them were involved in the press conference. Those kinds of things go a long way to help normalize conversations about things that can often carry a lot of stigma. Does anybody know who this is? We have any Baptists on the call? So that's Jerry Young. He is pastor of one of Jackson's most influential congregations, which is called New Hope. He also happens to be president of the National Baptist Convention. That's a picture of him preaching about HIV. Like I said, pictures worth 1,000 words. Pastors are willing to do this work. We just sometimes need to work with them to do it in a way that makes sense for their church. Dwayne Pickett is on the left, is the pastor of a mega church in Jackson. He's got about 4,000 or 5,000 members in his congregation. It's a picture of him preaching about HIV in New Jerusalem. We also brought in Al Sharpton for a big event at Tougaloo College in Jackson. That also enlisted a lot of pastors in our movement. So, you know, we have to do things a little bit differently with churches. We need to be creative. And we need to have prayer breakfasts and events that are akin to the ones that they're used to having, rather than the way that we're often used to delivering our services. Again, these are, I'm flashing the most influential pastors in Jackson. Ronnie Crudup has the biggest church in Jackson, taking an HIV test from the pulpit right there. Then we have Joe May on the right preaching about HIV on World AIDS Day. Now, what's the state of the science? I'd mentioned I want to take you guys to the frontier of what's happening. We know that pastors are willing to do this work. They've told us how to do it. We've developed programs for it. Most clergy believe they do have a moral imperative to respond to the health and well-being of their congregations. They are willing to promote, and this is where the science and the programs need to go in 2020. Pastors are willing to talk about testing. They are willing to talk about adherence. They're willing to talk about treatment. But a lot of them have never heard of U equals U. A lot of them have no idea what PrEP is. A lot of them don't know how important treatment is, prevention is. But if you talk to them about these things, they will ask you for educational information and are willing to do the work, but we need to bring them along and educate them and enlist them in this conversation to help them understand exactly how we can do this. A lot of them have said, Dr. Nunn, I'm willing to do whatever, but you need to tell me exactly what it is we need to do and help me craft my message so I can get it down. Or we want somebody else to come and give it so it's more precise. A lot of them also believe that there's power in numbers, and working together in coalitions is something that comes up again and again. If you can get clergy to work together on a few things, you can really help elevate entire you can elevate the dialogue in a way that brings along thousands of people. This is an article that we published in Ethnicity and Disease. Again, here's some pictures for you guys. What do we need to do? I think we got to bring together where the field is with biomedical interventions, HIV testing, treatment, and PrEP. We have done a pretty good job in some places of getting pastors to endorse screening, to talk about screening and to offer screening at health fairs. We have done less well in getting them to talk about treatment and the importance of treatment is prevention. Most people do not know that you can take one pill once a day for HIV, and the HIV is a lot easier to manage than diabetes, for example. So we've got to figure out how to get pastors involved in this conversation, involved in the ending the epidemic movement, and really think about how we can bring pastors into the fold to work with community health centers, most especially in those hot spots and in rural areas where there's very little community infrastructure. I think we also got to get pastors to talk about the importance of embracing and affirming the dignity and the value of people living with HIV or people at risk for HIV. These are things that they're willing to do. We just need to be reaching out to them for partnerships of these kinds. I think they can also do a lot to help us normalize HIV screening and care. This is a pastor looking on right here. This is one of my trainees, Dr. Sharon Parker. This is her teaching both Jerry Young and a young pastor here in Jackson about the HIV care continuum. This is my Faith in Action team in Jackson. Now, how do we do this with community health centers? I think these things can absolutely go together. This is a brief slide from a project we did with the Federally Qualified Health Center in Philadelphia, Pennsylvania, where we tried to routinize HIV screening. So what we did was we worked with a federally qualified health center that was in a community with extremely high rates of HIV infection, but that was using a risk-based offer to HIV screening. What does that mean? Only people who asked for a test or that the provider thought was at risk were getting screened for HIV. That means that this health center with 20,000 unique patient visits a year, only about 15 people a month were getting screened for HIV when we started. When we, this is an example of what happens when you introduce new screenings as part of a protocol at a federally qualified health center. This bar here represents the number of people who were eligible for screening. This means people of reproductive health age, basically, the green bar. So these are the people that were eligible. These are the people that actually got offered a test. And these are the number of people that accepted. So basically, we know that when we tried to routinize screening, our challenge was to get this red bar up there on par with the green bar. In the real world, even when you want to do a universal offer for any screening, it often doesn't happen. So what we were able to do, and you can see how these numbers bounce around. Oops, sorry about that, my mouse is jumping. And the blue represents the number of people we actually screened. This on average level, was about 27% of all comers to the clinic, which was pretty good. That meant that over time we screened about 11,000 people. But we found that a lot of people declined testing because of stigma or because they thought that they often weren't at risk for HIV. The other thing that we discovered was that there was big challenges with the universal offer. In very busy clinical settings, where there are so many other competing demands on provider time, it can often be hard to normalize screening. But you really can do it if you are committed to changing the norms and the clinical protocols at the clinic. Similar things happen for PrEP in real world settings. We've done a lot of research about pre-exposure prophylaxis in a 3-site cohort that includes Mississippi, Missouri, and Rhode Island, where some of our trainees and other colleagues live and work. What we have found is that we've done a pretty good job of getting high-risk folks who really need PrEP onto PrEP in community health centers, in unconventional settings, also in STD clinics. But we lose about half of our patients at the 6-month in mark. So we've got a couple of studies to try to figure out why. Some of the reasons are that people enter monogamous partnerships. People often get tired of taking medication if they're not sick. One thing that we learned is that people drop off often at the pharmacy point of sale when they get hit with a big deductible or copayment. So all of those things have to be taken into consideration when we're thinking about how we retain people in PrEP. In my mind, it's easier to get someone on than it is to retain them. The devil is in the details of figuring out how to keep people, how do we overcome the social and structural factors that undermine retention in PrEP care over time. We've developed some interventions to do that at some small clinics and also some big ones in those 3 sites that I alluded to. What we found that really works is patient navigation. The Ryan White program provides wraparound services for people living with HIV. One of the challenges with PrEP is that there is no payer of last resort. And so a lot of patients on PrEP are not navigated because there are not federal resources for patient navigation for PrEP. We have been vocal advocates about trying to get more folks about getting the federal government to foot the bill for PrEP navigation as part of the Ryan White Care program. That's something that we've been really committed to. And we know now that this study's been completed that navigating PrEP patients makes a huge impact on whether or not they're retained in care. So I think the next thing is kind of bringing all of these things together. We know how to do this with health centers. We know how to scale up PrEP. We know PrEP navigation works. We know that clergy are willing to do this work. And we have some models for what works for screening. Now we've got to bring clergy into the fold to help normalize screening and treatment in those hot spots, to help normalize PrEP and bring up all of these things together. We also need a massive federal investment for working with faith leaders. To date, there has been very little infusion of federal resources, either on the research side or on the program side, to facilitate those kinds of linkages. This is an article we published in AIDS and Behavior calling for a massive influx of federal resources to work with African American clergy and Hispanic clergy in those hotspots. And I will stop there. Just want to thank my family and my team that makes everything that I do possible, and also give you guys my Tammy Faye picture and my contact information.
Okay, we will open it up for questions. Please feel free to ask questions or comment. She's here to answer those for you. And you're all unmuted, so you will not need the chat box.
Hey, Amy, it's Eddie. Great talk.
Thank you.
Do you find that in the federally